I'm here to recap the third edition of the HIV Clinical Forum Chinese series, talking about optimizing HIV treatments, pharmacological considerations. We had 3 talks in this third series, the first of which was presented by Professor Andrea Calcagno, talking really about the pharmacology of integrase strand transferase inhibitors. He started off by really telling us what we now know to be true, which is that most international HIV treatment guidelines favor and recommend the integrase inhibitors as a integral part of these new regimens. He presented some data on the safety profiles of the various integrase inhibitors. Generally, they have been found in both clinical trials as well as everyday experience to be very, very safe in terms of their use. There were some concerns, or there are some concerns about specific integrase inhibitors. For example, the relatively low genetic barrier to resistance of raltegravir and elvitegravir, the twice daily dosing of raltegravir, the need to co-administer elvitegravir with a pharmacologic booster like cobicistat, for example, the relatively newer integrase inhibitors like dolutegravir having concerns with weight gain and a somewhat increased signal of neural tube defects in women who are pregnant, especially in the first trimester, while taking dolutegravir, and the fact that bictegravir is currently only available as a singlet tablet regimen. However, these concerns, I think, pale in comparison to their effectiveness and to their general good tolerability in people who are taking it. He then, went through some of the pharmacokinetic and pharmacodynamic considerations and features of the integrase inhibitors, with a special focus on the fact that the second generation integrase inhibitors like dolutegravir, bictegravir, do seem to have a very high genetic barrier to resistance, and this is coupled with the fact that they tend to maintain a high degree of activity even against HIV mutants that have integrase resistor associated genetic mutations. There was some focus on the neuropsychiatric effects of dolutegravir specifically, focusing largely on things like insomnia and as well as a slightly increased signal of headache, but the fact that these do tend to be reversible after stopping the drug. There was a focus as well. Dr. Calcagno talked about drug-drug interactions with dolutegravir, especially since it's probably one of the most widely used integrase inhibitors now, including the interactions with metformin, for example, as well as the rifamycins, and the concerns of reduced absorption due to chelation with metallic cations should they be administered at the same time, and how these really should inform our prescribing for patients who are on both of these medications. He then sort of ended off his talk by talking a little bit about cabotegravir, which is really on the horizon as the next integrase inhibitor that is likely to hit the prime time or more wide use, especially since it is a long-acting integrase inhibitor that can be used as an injectable drug together with rilpivirine. Then we talked about, we went on to the second talk by Professor Francois Vonte, talking about adherence considerations in the choice of antiretrovirals. And Professor Vonte really gave us a historical look at how antiretroviral therapy has changed the lives and the entire landscape of HIV care, where HIV care is now a controllable, chronic, and manageable chronic disease due to how effective antiretroviral medications are. But this also then means that people living with HIV will grow old with HIV, meaning that their life expectancies now approach that of HIV uninfected individuals. They are looking at a lifetime of treatment and possibly also with other comorbidities and polypharmacy. And hence, we really need to start designing HIV treatment regimens that fit in with this longer duration of taking medications, in short, making them easier to adhere to, more tolerable, safer, with fewer side effects. This is even more important because we now know for a fact that undetectable equals to untransmittable, and treatment as prevention really helps to prevent the onward transmission of HIV. And hence, there is an even greater reason for us to design antiretroviral regimens that are easily adhered to, because it has a public health implication as well. The more likely that people are going to stick to their treatment, the less likely they are to transmit the infection to their partners. And hence, we really need to look at why people don't take meds, right? Whether they be drug issues like side effects, pill burden, or toxicities, systems issues like difficulties in getting access to treatment, or getting to clinics, getting their lab tests done, or human issues like mental health problems, poverty, socioeconomic disparities or iniquities that all need to be addressed before treatment can be reliably and sustainably adhered to. And this was really the call to action that Professor Venter had in his talk, to challenge us to find regimens and drugs that meet all these criteria. And then the last talk was delivered by myself, really talking about switching antiretroviral regimens in order to increase adherence. And what I tried to do in my talk was to build on the data and the experience shared by Professor Calgagno and Professor Venter. I talked about the importance of adherence. I think something that we take for granted, but there is very good data to suggest that better adherence leads to more sustained and durable viral suppression, that certain regimens tend to be better adhered to than others, including the integrase inhibitors, as well as some of perhaps the more modern or the newer protease inhibitors, and that there are some strategies that we should use when we're thinking about switching regimens, looking at what were the previous causes for non-adherence, and really trying to design regimens that have fewer tablets, that have fewer side effects, and that need to be taken fewer times a day. And I offered some experience from not only international recommendations, but also the local guidelines that are used in Singapore. And that ended off with a few case studies from my own clinical practice, where I've had to change regimens to try and enhance the adherence to these regimens. And we closed off with a really interesting discussion with great questions from the audience, looking at concerns about certain resistance mutations and what they mean for integrase inhibitor use, as well as some strategies in incorporating not only pharmacologic but non-pharmacologic strategies to try to get people more adherent and more on board with their treatments in the long term. And I really hope that, at the end of that session, people came away with a better understanding of how we can harness the advancements in medications to make HIV treatment adherence much easier. Thank you very much.